the next part is an informal Q&A panel. And we've got 2 panel members that have spoken today, and you do know who they are. But we've got 2 panel members that I'm going to ask to introduce themselves in a moment. I've been sent a few questions in advance, and then I'm going to open it up to the floor, and we have our lovely Jane there with the roving microphone. So we've heard all sorts of information and inspiring information about what's happening. This part is really your opportunity to engage with the presenters and workshop leads and colleagues. So could I ask Jess, could you introduce yourself, please?
Hello everyone, I'm Jess Berry and I'm Head of Health Inequalities for the Integrated Care Board.
Hi, I'm Katie Dixon. Primarily I'm a GP. I also work in Jess's team at the ICB, and I've got an ICB adult safeguarding job as well.
Thank you very much. So I'm going to start with the 3 questions that I've had submitted to date. The first one, and I'm going to ask you to choose who wants to answer them as you choose. So the first question is, what do the panel think the public perception of social prescribing is? So what do you think the public perception of social prescribing is? Who would like to start?
I'll start if you like. As a GP, I'm often sitting with a patient that's got various vulnerabilities, and I think our social prescribers, who are amazing, big shout out to Jane, who's near the back, might be able to support them. So I obviously want to introduce this concept to the person that I'm talking to, and usually if they haven't come across our team before, what I get back is a completely blank look, as if they haven't got a clue what I might be talking about. So my first sort of thing is they're not a social worker, because obviously some of these individuals will have had interactions with social services before, which may or may not have been problematic from their perspective. So I think really people don't know is my impression that I get.
Okay, anyone else like to?
Yeah, just to add, I think the language is important, and I think we have to be careful. It's known within kind of this audience, social prescribing. We understand the term, but that it can have mixed kind of connotations, and I think it's important to kind of put it into context around helping people to help themselves is often a kind of phrase that I use, and it's really kind of, you know, working to people's strengths, and it's how we describe and articulate what it is. The other thing I do get feedback on, and to be honest, is, you know, is it a kind of excuse to not be able to see? Obviously there's a lot of pressure on being able to get access to GP appointments, and is it kind of fobbing off with a cheap and cheerful alternative? And I think we have to be very honest about that, and not kind of hide from that, and actually kind of face up to that and say, yeah, but it's not an alternative to seeing your GP. It's a way of getting a better outcome for you, because the answers, as clever and as all-encompassing as GPs are in terms of their knowledge and experience, actually we know, as we've already talked about this morning, that a lot of solutions lie within that wider community. So how can we really harness that? And that is I think that's a cultural issue that's going to take time to overcome and for society wider to become accustomed to. So I think we've just got to be brave about that and not hide away, and challenge in a gentle way, not you know, still allow people to see their GP and to access GP services and healthcare services, but actually use this as an enhancement to that.
Okay, thank you. Any other comments on that? Right, second question then. How does the panel feel social prescribers help improve physical and mental health outcomes?
So if you think about how our health is made up, the King's Fund particularly has some good statistics on this. 80% of health outcomes are determined by wider determinants of needs, and if you think that's the bread and butter of social prescribers, those non-medical interventions, and I have broke it down here in front of me. So 50% is socio-economic, 30% is behavioural and environmental, and only 20% is around healthcare, so the other 80% is non-medical. And I think for those who sort of know about Maslow's hierarchy of needs, people may remember that. It's not quoted so much more anymore, but I still use it because it's a good foundation to think about. If you think about that lower tier around the physical bits you need in your life, around food, warmth, security, housing, those are some of the real basic needs that people need that you're helping people with. Then you move up to things around safety, and people will be working with people around employment and how to feel secure. And I think what social prescribers are really well known for is connecting people to community and groups, and that's really important in that sense of belonging. So that just those 3 steps, and there's more that lead up to self-actualization, but those levels need to be gone through before people can start to self-manage and make changes for their health.
Thank you. Any other comments on?
Yeah, and I'd maybe just add to that, sort of helping people to then help themselves, so those community connections, that kind of resilience for their own sort of future and their own outlook, but also helping to make those social connections that kind of keep them well for longer, that help people to look after their house, to make those connections, those friendships, so that they're more reliant on their support network as opposed to coming for medical interventions that aren't really going to solve the problems.
Okay, thank you. Is that okay? Third question sent in advance. In your experience, how does partnership working improve outcomes for people with complex or multiple needs and challenges?
I could probably quote several examples of my practice sort of over the last 30 years as a GP. And I think with our most complex medical patients, often there comes a high degree of social complexity, whether it be, housing difficulties, financial difficulties, substance or alcohol use, loneliness, all sorts of things. And I think if we take a sort of combined approach with other organisations and our social prescribing, I think the key would be link workers here, can connect us into those other resources within the community to help solve that. And it might be getting that person to their appointments. It might be somebody who can sit down and spend more time with that person to encourage them about the need to go and have their blood tests. So that we had an example of somebody who was about to have their renal transplant medication stopped because they hadn't had a blood test or agreed to one, and these drugs are dangerous, you have to have it monitored. And just bringing together a team of people to try and explore what the issues are, involve the person most importantly so that they feel part of that process and they're not effectively being taken over, but to try to gently convince them that these things are a good idea and are possible. So I think that's really the key. Anything to add?
Just to add, I think services work best, particularly for people with complex needs, and where partnerships come into their own, is where we wrap services around the individual. So we see a lot of this in things like children's services, and where we're supporting families and actually having one agency that holds the lead for that particular individual or for the family, but then brings other agencies together. But the services, it's not about passing somebody from pillar to post to 3 or 4 different services. It's actually coming together as services and wrapping it around that individual so that they get the support they need in the way that they need. They build those trusted relationships with key individuals, no matter what agency it is. And it could be the voluntary sector, it could be in the statutory sector, it could be in health, it could be in public health, it could be in adult health and social care, it could be in children's services. But they actually get that support that they need, and it's the services that work in partnership, not the individual expected to navigate through several doors to find the right service for them. So I think that is the key. The challenge is, do we do enough of that? Are we doing enough of that? Are we brave enough to actually put the time and resource into making that happen in the way that we need to? I see some really good examples of where it does work, and arguably, whilst we would never want to have anything like the pandemic again, where it did work was during the pandemic, where we put people first And I know we didn't quite have bottomless pits of money, but we wrapped services around vulnerable individuals to support them. Some of that, I think, has waned since that difficult period. We wouldn't want to go back into a difficult period to trigger that again. So what can we learn from that? How can we apply ourselves and our services slightly differently to make sure that we're not duplicating unnecessarily and trying to build the same relationships with key individuals?
Thank you. Sam?
I'd maybe just add a short point onto that, talking to the sort of partnerships rather than pathways element of it, is that stability within that the complexity that person's dealing with, that's the single biggest difference that I think these partnerships can make. Yeah.
Yep, that's great. Okay, thank you. So those were the pre-sent in questions. And now I can see one hand up. I'm going to start giving you the opportunity. Yeah, I'll come to you next. Giving you the opportunity to start asking the panel your questions. If you can just say your name and which organisation you're from, please.
Hi, thank you. I'm Emily Corral. I work for Energise Me, which is the active partnership that covers Hampshire and the Isle of Wight. Wanted to jump in because I've got a question really related to that. When we talk about neighbourhood working, when we talk about partnership and multidisciplinary teams needed to surround an individual sometimes, how are we working on how we share data, information around that? Because what we're seeing is we want this cross-partnership care, whether that's community organisations or health organisations, however it might be, but we want to be able to share some of that outcome, share how the services are working for an individual, and so that single point of coordination has a very good understanding of what services are involved and how an individual's health and well-being is being supported, progressed, all of those other things. So just maybe this is a question for Samantha with thinking about some of those systems. How is that progression with data and sharing sort of being really looked at with this work?
Okay, thank you.
Yeah, so I think this is a sort of specific work stream that Alliance 42 are working on, and I mean, it's the same with everything. There are pockets of really good practice on this, so giving proportional access to patient data to multidisciplinary teams, but also the voluntary sector as well. And both the voluntary sector as service providers, and also actually, is there a part for kind of infrastructure within that access as well? And there are a couple of really good examples, which I do not have off the top of my head, but I can share them and go out afterwards. And I think it feels like this is one of those issues that kind of bubbles away, but there's never quite enough time and resource and headspace in these conversations. It kind of always falls off the table a little bit. So I think there's stuff that Alliance 42 are going to try to do nationally to kind of raise this, and then we'll kind of support, and then more of a kind of a voice locally to sort of push for that as a priority, because you're right, yeah, it's such a blocker, and it's really frustrating for the people that are kind of going through these processes and working with multiple partners.
Thank you.
I can answer to a point, but the gold standard of sharing information, I know, is been difficult for years. But in the ICB, we have something called Healthy Intent, which is a population health platform. And that is all the primary care data, secondary care data, and acute data, all in the same place. So you can see any overlap and linkages. You can see spots of where they've had contacts with certain agencies, and all primary care have access to this, and they can have the PID, so they can do case finding, etc. But yeah, we're some way off of the voluntary sector and sharing information with them. I don't know if you use Health Intent.
So I think probably from a frontline practitioner perspective, it gives you a sort of different view on the idea of data to be used as a sort of population health analytics, because I'm one of the people inputting the data, so I know how variable the quality might be, and I think that's something that we need to be careful about. So sort of a lot of frontline practitioners are probably not very good at recording data in a coded way so that it will get picked up on a search or picked up by these various other external platforms that are tapping into the massive data set that primary care is. And then I suppose, you know, on the other side of the sort of data side of things is the, you know, information sharing with external agencies and the you know, governance around that, which is really, really complicated and often a sort of blocker or a barrier to individual patient care at that level.
Yeah, I'll be honest, I don't think we are smart enough in the way that we share data at the moment, and it's an area that whilst we've made some inroads, I think there's a lot more we could do and should do. The other area that I think is really interesting and is an area that is constantly kind of evolving at the moment in a very rapid pace is the application of AI in population health. There's a piece of work being led by University of Southampton that I'm involved in, and some others in the room may also be involved in, around the application of AI in civic society and what that tells us, and health is a key component of that. I've got a workshop on Friday down at the university that I'll be involved in and starting to explore that, and I'll be happy to bring that back to the network to gain some insight from yourselves to see if there are some applications we can start to use. But I would think that we need to be better at sharing the data than we are at the moment.
Okay, thank you very much. We had a hand up here. If you just wait for the... Oh, while Jane's at the back, do you mind saving her toing and froing? Do you mind if Jane...
Hello, my name is Penny and I am a dental hygienist, and I specialise in delivering training for healthcare professionals, individuals and the vulnerable people. I just wonder, what is included in your social prescribing for oral health care? As we know, prevention is better than cure. Our oral health is connected to our general health biologically, and it affects our well-being as well. I think we all know that the void is getting bigger and bigger, where people are not receiving basic essential oral health care, and we have many people who are trying to live independently at their own homes, which I salute greatly. And people are often wanting to spend their last days in their own home. Oral health care is essential at this stage of end-of-life care. I have tried previously to introduce it into social prescribing with our GP's practice. We got so far and it was turned down as deemed unnecessary. I am often approached by visiting nurses and other members of the profession wanting some help with oral health care because they don't know where to start and they don't know what to do. So I'd be interested in what your answer is, and is there any way forward that we can improve the situation? Thank you.
Okay, thank you. Jess?
Yeah, I'm no expert on oral health, but I do know some projects that are going on just because they're connected to health inequalities. And if you are familiar with Core 20+5, there's also a children's one, and oral health is one of the objectives in that. And as such, I know that there are some teeth brushing schemes happening in schools. But also, the ICB actually commissions a mobile dental unit, and it's called, anyone might have heard of it, Dentaid, yeah. That's right. And we've been out and about, well, not me personally, but the Dentaid team have been out and about in areas with poorer health outcomes, including onto a Roma Gypsy traveller site, and that is getting some good outcomes, but I agree. I mean, the oral health is really important. In terms of social prescribers, it's difficult because they're non-medical, but knowing where the bus is going to turn up and knowing to advise parents that there might be a teeth brushing service in their school is probably the best they could do in terms of signposting. I don't know if anyone else. Oral health, not my expertise.
Not my expertise either, but I think you make a really good point, and I think it is overlooked, isn't it? And I think it's great that you're here today amongst lots of social prescribers and amongst all of us, and hopefully we can sort of take on board your comments and move forwards. I think the development of a neighbourhood health service is an incredible opportunity. I mean, we're really only at very much the planning stage at the moment. But I think the idea would be that not necessarily everything all under the same roof in all of these neighbourhood health centres, but I think we absolutely have to, take on board the sort of, pharmacy, optometry, dentistry, and general practice, because at the moment probably general practice, as in GPs, get a much bigger voice than any of these other services. But I think we need to just make sure that that's not sidelined going forwards, don't we?
Okay, thank you.
Hello, it's just a question for Jess, really.
Can you just say?
Yeah, I'm Sarah. I'm a social prescriber at GP surgery in Portsmouth. And just want to understand a little bit more. Obviously, we're trying health inequalities and trying to link in with communities. Does the ICB fund GP surgeries? Do they get funding to help with projects that are in the community? Because from my perspective, it's really frustrating. I think there's more we could do through our surgery into the community, but we're often told there isn't a lot of funding available to do different things.
To be honest, there probably isn't specific funding for community projects. I mean, there used to be, we used to have a personalised care fund, which we used for such a thing. However, that was withdrawn from NHS England some time ago. However, I don't know details, but we're now doing what we call a fairer funding model with primary care. So where there is areas of more need and worse outcomes, GP surgeries will get a budget to reflect that, but that might not be ring-fenced for community projects. That's the problem. It could be ring-fenced for extra doctors, etc., etc. But if you are working in an area of deprivation, it's more than likely that your practice will be part of that fairer funding model. And I think through things like this social prescribing network, the health forums networks that Community First do, is a good opportunity to find out about if there's any seed funding. Because believe me, £500 can go a far way for a community project. And it's about, keeping your eyes open and us keeping our eyes open for you for those small sparks, bits of funding.
Yeah, I can't really answer the question specifically about ICB funding, but one opportunity might be to work with local infrastructure to ascertain what exists in the community and to see if there is access to charitable funds that charities and community organisations. So whilst it might be something that you as a surgery would like to do, the answer and the solution may lie in what can the community do to try and raise funds, to come together, to work collaboratively with you to access funds that wouldn't be available to a surgery through charitable sources, but actually develop a programme or a project in a particular community or around a particular health-related theme in a particular neighbourhood. Happy to signpost to Portsmouth organisations that can support you with that, or indeed ourselves as Community First that work in the sort of Fareham, Havant, Gosport and the perimeters of Portsmouth as a city. I think that might be the opportunities. I think, from an outsider to the NHS looking in, I think resources are so incredibly stretched across the system that it's very unlikely that despite the shift towards help at home and towards community and neighbourhood care, that there's necessarily going to be a shift in the time frame that we would like to see in the resources being able to follow suit, because there just isn't enough flex in the system to allow that to happen. So I think we're realistic about that. I'd like to see more money go to surgeries to help fund community projects, but I just don't think realistically it's going to happen. I think the solution lies within the community itself.
Thank you. Okay, any other questions? Yeah.
Thank you. Sue Foster, I'm the Disability Employment Advisor working for DWP at Winchester Job Centre. And Tim has given me a fantastic segue into my question, which is amazing. Thank you very much. You've talked very much about the collaboration and wrap-round services or support for individuals rather than the expectation of them navigating the services for their benefit. Can we also look at how a wrap-round service could be used for those who've identified particular needs and want to progress, maybe putting in some service for that? Could that wrap-round service be supported by those who are thriving, those organisations that are thriving, who are able to have good example of practice, to be able to do that rather than, and can that wrap-round service be supported in order to increase the amount of resource available to individuals?
Absolutely, and always my advice or my go-to is always start with what we've got. Start building on organisations and services that are already providing services and support. And if there's a need, the other point I think in your question, Sue, is about evidence of need. So that's what helps when it comes to bidding for external funding. It's all about where is the need, what is the need, and identifying that very clearly and concisely and precisely. And if we can identify the need, then yes, there will be undoubtedly existing organisations that can grow and extend services. And some amazing services really start off as quite small and focused around a particular cohort of people or a particular geography, and then extend because the demand or the need is there. They might scale up and just work across a bigger area, but equally they might find other people with the expertise that they don't have but can plug into them to deliver that. And yeah, health-related needs are really good at that. I don't know if others...
Yeah, and kind of linked to the sort of evidence of need and back to the data point, also evidence of impact. So if you've referred on to services, you've seen an impact, it comes back to sort of data sharing. If you can share those insights, that's going to support those community organisations to get that fund and make them more fundable to develop those services. To either in terms of how many people they can take on one site or to kind of spread that geographically. I don't know if there's anything from an ICB perspective that I guess supports more funding or development for those kinds of initiatives. No.
Sorry. No, that's fine. That's fine. Okay. Okay, thank you for that.
I suppose what I'm also looking for is to say, if you've got the evidence, you've got looking at the impact, you're looking at what could possibly be done, I'm very much into pictures. Draw me a picture is not a rude thing to say to me. Can we actually then say, there are a group of people, there is a group of people who can say, right, okay, we'll get around you as a small group, and we will nurture this to see whether it's a goer, what's going to happen, how are you going to do this? Because otherwise it can be quite isolating. And if you've got full-time jobs doing as well, that's quite a lot of time to consider. And other people voluntarily put in time. How can we wrap around this service around other small either organisations, agencies, to be able to do this as well as much as the service, somebody who's an individual trying to find a service.
So I think, again, you've given me a very nice segue to give a plug for this. This is absolutely what you've just articulated, I think, is partly why Community First, and there are other colleagues, my colleague Donna from Rushmore Voluntary Services in the room as well, that provide that local infrastructure support. So we are here to help any individual or small organisation or group of people that would like to develop a pilot initiative or a project. It might be about connecting you up with a group that we already know that exists in the area, or it might be about saying, absolutely, what you're coming at, your idea is novel, it's new, it's innovative. We need to let's see if we can get some funding in to support that and whatever costs you've got. If you've got a group of erstwhile volunteers who are willing to put some time in, we're happy to help. It may lead to a new group being established. It may, as I say, just be something that we can connect up with another group. But as an umbrella organisation, we're really keen to support and grow ideas. It's not about us as an organisation taking everything on under our umbrella necessarily, but just being there to support, nurture, encourage, plug you into to other people. So I'd love to pick that up with you, Sue, yeah.
Thank you.
You've clearly got an idea there, I think, haven't you?
Yeah,
yeah,
if you've
fantastic.
got something in mind, your local Council for Voluntary Services would be a good start.
Thank you.
So thank you for that. Other questions? Any other questions? Oh, sorry. Yeah, just one sec. Jane, at the front, and then if you can... Okay, thank you. Well spotted, thank you.
Hi, I'm Kate Riddle, Health Liaison Officer for Alcoholics Anonymous. How far do you see groups such as ours that have traditionally been stigmatised being recommended and embraced by the NHS, healthcare, social prescribers across the county, especially when we are very supportive of places like inclusion. But it sort of seems to be, and the feedback that a lot of our members give, is that there is this lack of knowledge of what AA does, which is astonishing considering it's 90 years old. So it's really just sort of find out, you know, how far, you know, do social prescribers and how much do you guys know about organisations such as this?
Okay, thank you. Who would like to start?
I'll take that to start with, if you like. I suppose as a GP, we tend to be thinking inclusion first, because that's the sort of the NHS service, and you know, that's what we're familiar with. And I suppose it's probably a lack of knowledge into exactly where AA fits in that sort of in the spectrum of other offers and support that there might be. And I suppose that's where we might rely on, for example, our social prescribers to sort of know a little bit more than we do about the other potential offers that there might be, and the pros and cons of pointing people in a slightly different direction sometimes.
I mean, I don't work directly with patients, but I know plenty of people in my personal life that have really benefited from AA. So personally, I would recommend it to anyone. I just wondered, maybe a show of hands from the social prescribers, if you've referred or any of your patients have used it and had positive experience. So, yeah, we've got quite a few.
We've got about
people.
15, 20 people have got their hands up.
Yeah. Yeah, so I mean, I think it's totally different from inclusion. Inclusion is regulated by commissioners with KPIs and et cetera, as my understanding of AA is it's totally independent of the sort of any authority or you know, KPIs, etc. So if you don't promote it and you want to find out more, do you speak to this lady. What's your name? Kate. Yes, speak to this lady on lunch or go to their websites, so you're better informed. Thank you for that question.
Thank you. Okay. There was a... Oh, Jane's running.
I'm going to have to run.
It's keeping her fit. She doesn't need to go to the gym tonight.
But I am.
You are going?
At
okay.
4 o'clock.
It's a warm-up.
Hi, I'm Lindsay. I work for a charity called Recovery Connections, and I'm just following on from what Kate said. So our primary focus is being the bridge between structured treatment for people with substance misuse and leading a normal, whatever normal is, life. We run an ambassador program, which is training people, level 2 qualification to train people to be peer mentors, and then those people, once they've finished the ambassador program, can then volunteer. And the idea is that we set up community groups to help people, whether it be training, coffee mornings for connection. So, you know, following what Kate said is how do we get in with social prescribers so that people can be signposted to our groups, so it can help their recovery, it can help them go on to lead a normal life. Yeah, so what would be the best way to have our services be part of your social prescribing?
I guess so. As we kind of spoke about before, the sector is huge. There's an awful lot of information and groups for social prescribers to be on top of. And I think it's just about making yourself known. It's that tension between how much time you put into supporting your beneficiaries and how much time you support into kind of plugging yourself into the system. And I think that's where kind of communities first and organisations like that kind of come in to support that. But yeah, it's kind of it's making those connections and making yourself known and doing that kind of periodically, because yeah, the ecosystem is massive.
If you operate in Hampshire, the stall over there, Connect to Support, would be really useful if you put your information on there. It's really easy. You go to Provider tab, upload your service. But also there's an opportunity, if you're not already part of the social prescribing network, and have got here through other ways, make yourself a member and you'll get newsletters and things. And we can always put if the information about services in those newsletters, or if it's something social prescribers or the health forums want, you can sometimes sort of do a show and tell at one of their virtual webinars. So yeah, get in touch. There's lots of different ways.
Thank you. Did you, Tim? I think Tim wanted.
So I think those sort of last questions, you know, what comes out for me is the value and strength of peer support. So these models of people that with lived experience of helping other people who've gone, everybody's story is unique, but have gone through similar experiences and can share that, learn from that. And it's a bit like with the veterans, you know, you've got some connection. And that's really powerful, important. For me, that's one of the fundamental things about social prescribing is finding those connections for people and helping them to help themselves. You know, AA is something that people choose to do and commit to with the support of other individuals. I think those are incredibly powerful because it's people making the choices to help themselves. And that's the bit that I think we shouldn't lose sight of. And if there is a way that the social prescribing network, we can better promote those peer-to-peer services and support and maybe advertise particular groups, or if you've got particular locations across the geography of Hampshire and the Isle of Wight that we could particularly focus on, I think we could do that. We can always, I know Angela's so super organised that we've always got the kind of next few social prescribing network meetings always planned out with themes, but perhaps in my head now I'm thinking and speaking at the same time, but something about the value of peer-to-peer support, obviously, and just bringing together perhaps some different groups that really, you know, can demonstrate the value and impact of that would be really powerful for the network to do and focus on, and maybe, dare I say, even a theme for a future celebration event around really showcasing and highlighting the peer-to-peer stuff that goes on. Yeah.
Pop it in your QR feedback and we'll pick it up because we do take from that. So I've got a couple more minutes for any other... Oh, my word. Okay, 2 questions here. Yeah, that's fine.
Hello, Marie Adams from Fareham and Porchester PCN. So the social prescribers get involved in projects which just appear in a GP surgery. Currently, we're doing the frailty. It has a knock-on effect of 300 patients. No one spoke to a social prescriber before it happened. Also, there's a lot of uncertainty about the neighbourhood development and how it's going to change and the roles of social prescribing. No one seems to be talking to social prescribers per se. I'm not talking about going through an organisation. There is no information coming from anywhere apart from the meetings I attend, which are national. This is a real concern. I mean, we are really concerned about our futures, about the changes that the neighbourhood social prescriber work could take us. And if you continue giving us projects, we're going to have to deviate away from the core work we do, which is taking a long time with our patients to obtain a really clear, strong outcome. And I don't think that's really understood of how we've developed our role over, as you say, 10 years. A lot of us here have been doing this for 10 years, and we are very central to our surgeries. And it's just, oh, the social prescriber will do it. Well, actually, we need to talk with somebody at a higher level and not just through our GPs to actually get understood the work we really do. And yes, and we're not signposters. We refer people. We are professionals, okay? And we shouldn't be just seen as somebody in the surgery who will just take on this extra bit of work, because we're fed up with it.
Thank you. Thank you. Okay, who would...
I'll make a start on that one. And I probably need to apologise to start with, don't I? I think we're waiting for the neighbourhood contract to come out, and until that comes out, we don't really know what the future holds, because there is no detail around what the sort of, what the contract's going to have. So I can't really answer that question. What I am aware of is that as probably all your social prescribers will be aware, of the funding mechanism for your roles, which is the ARRS, Additional Roles Reimbursement Scheme. When social prescribers were first, out about, say 10 years ago, there weren't very many roles that were included within that scheme, so practices more or less didn't have a choice about whether they had social prescribers or not, and some practices or PCNs didn't know really what to do with their social prescribers. Now there's a sort of, a huge diversity in the roles that can be, bought with that funding, if you like, and I'm aware that some practices, some PCNs have chosen to, with the pressure on GP practice access, chosen to employ clinical staff instead, which I think is a great shame, and over my dead body will that happen in my PCN, but I can't, I don't have any control, and the ICB doesn't have any control of how PCNs choose to spend that money effectively. So I think yes, it is a big threat, and I'm hoping that the neighbourhood contract will have some sort of protection in there, but I don't know. We're not privy at the ICB to anything about what the contract will or won't have. It's all done at a national level. Probably doesn't answer your question at all, I suspect. Has anybody else?
Yeah, it was really unfortunate when they stopped ring-fencing the R's roles for things like health coaches and social prescribers, and I'm glad to see that lots of practices have retained those R's roles. But I mean, we don't know what the future contract will look like, but the nature of neighbourhood health is all about reducing health inequalities. So surely that's a driver to keep these kinds of roles. And what I will do is I will take it back in terms of those people that are developing programmes back at the ICB about keeping the wider workforce informed, because I'm sure it's not just you guys, I'm sure it's could be care assistants, receptionists, all sorts, wondering what this neighbourhood health is going to be for them.
Okay, thank you. I saw somebody else with that.
Hello, I'm Abby Roper from Vision for Youth. We're an independent charity and we run a youth social prescribing service for young people aged 11 to 18. We're in the voluntary sector. We've been running the service for a few years now, and we're quite successful receiving referrals from secondary schools and children's services primarily. What we struggle to get is referrals from GPs and local surgeries. And I just wondered if anybody had any thoughts on how that could be improved and whether there's anything that we can do to kind of break down that barrier between getting people in the practices in the NHS referring to somebody in the voluntary sector.
So I suppose, is your footprint very large, or is it quite a small, defined footprint that you work with?
It's fairly small, but it's growing sort of across the local district and borough.
So I suppose if it's fairly small, you might know who your PCNs are, do you? Yeah. And have you tried to communicate with them at all? Just with not much success? No, that's a tricky one, isn't it, really? And I suppose leveraging any relationships that you have with the local area and trying to sort of explore, probably going in through any social prescribers that those PCNs have, but bearing in mind the last question and mine and Jess's responses to, some PCNs have very few social prescribers now, so that might not necessarily be as useful a sort of segue into the PCNs as there could be. But I suppose interacting with whatever is in your local area as best as you can, maybe even speaking to, say, like the mental health services in the area, something like that, to see whether there's any connections in terms of a route in. Tricky though if they're not willing or wanting to engage, which is an enormous shame for their patients in my view.
Okay, thank you. Is there any other burning questions? No?
Got the answer. Yeah.
Oh, sorry. Oh, sorry, Sam.
I don't have the answer, but I was just gonna say, have you spoken to those PCNs around what their percentage of youth, how many young people they see going through their services? Because it might, I don't know, and it's been a while since I've worked in social prescribing, but it might be the percentages, and I'm sure lots of people in this room could sort of maybe give you a bit of a handle on how many are youth, how many referrals, how much of their caseload is youth versus adults potentially.
Okay, thank you. And our very last question is over here. So Jane, if you could
quickly jog.
Lovely. Just
where am I turning?
Here. Thank you.
It's actually not a question, so you guys don't need to worry. All it was as we were talking about promoting social prescribers, I've worked quite a lot around trying to get what social prescribing is out there to our audience of patients at Shakespeare Road. Sorry, I'm Kelly, by the way. And I put like a trifold leaflet together, and I've also got funding for TV notice boards in our practice. So what I've done is to gain exposure for my service. Not that I actually need to make myself any more busy than I am, because as we all know, the referrals come thick and fast. But I think what I'm trying to do is, obviously for the GPs, is to bridge that gap and obviously make the patients aware that if it isn't a clinical need, and if it is because they're suffering with isolation or befriending or whatever, they don't actually need to touch the GP. And I'm also trying to educate our care navigators to ensure that we are, the service that we give, they can give at front-facing within the surgery. So I think some of it is down to education in our own practices. We also use Facebook, and we also promote me on our PPG Facebook. I'm heavily involved with quite a lot of stuff with regards to integration, I've connected with our local hospital, so trying to forge those relationships also to streamline it and make sure that it is like a one-stop shop.
So lots of pointers and
but
ideas.
Lots of pointers and ideas. But I'm happy to share my trifold leaflet with you, Angela. Yeah. And if anybody
Katie can hopefully circulate it.
Yeah,
for you.
Of course. Feel free to amend, obviously, with your own logo and stuff, and change it up. But
that's
yeah.
Great.
Okay.
Thank you.
No worries. Thank you.
Okay. Can I say thank you very much to our panel and to the audience? Thank you very much.